Good morning. So, for those in the audience that are not familiar with transplant oncology, the concept really is relatively new. Uh, it incorporates the transplantation sciences, oncology, and technical advances in medical oncology, radiation oncology, in the treatment of primary and metastatic diseases to the liver. This also, thank you, integrates the science of immunology and as well as genomics in the individualized treatment of patients with primary and metastatic liver cancers. The first symposium on transplant oncology was held at the International Liver Transplantation Society in 2019, and we've subsequently held two other symposia. But I think it's important to realize that, in fact, liver transplantation, as defined by Tom Starzl in his book from 1969, states that liver transplantation was the unequivocal indication for treatment of primary hepatic malignancies that could not be treated by conventional techniques of subtotal resection. In fact, if you look at the early trials of liver transplantation, of the first 7 patients that received a liver transplant, in fact, 6 were primary or metastatic diseases to the liver. You can see that the early survival was quite poor and never really allowed us to appreciate the risk of recurrent disease in these early patients. But if you look at Roy Kahn's book in 1987, the second edition, what you'll see is by now survival of patients past the early postoperative period allowed us to understand what the risk of recurrence was. In the 46 patients that he reported, that's 32 of them which survived 3 months, 15 had no recurrence, 17 had recurrence. Of those that had recurrence, 13 died. And of those patients that didn't have recurrence, about 50% were alive. He also went on to show that several other malignancies that we now know have defined patterns. For example, angiosarcoma has had and continues to have a very poor outcome after transplantation, whereas neuroendocrine tumors have a fairly good outcome. Epithelioid hemangioendothelioma also is a relatively good tumor to have for transplantation, whereas hepatic malignancies, metastatic diseases had a poor outcome. So early on, our series of patients with HCC that underwent liver transplantation had a pretty poor outcome, 5-year survival rates between 20 and 40%. And this led then in 1983 to the statement by the NIH that primary hepatic malignancies confined to the liver but not amenable to resection, while it may be an indication for transplantation, indicate that the results to date a high likelihood of recurrence. And therefore, in the early eras of liver transplantation, HCC was not a covered indication for transplantation. Now, after some accumulation of survival outcomes, we could then define there were a group of patients that actually had a reasonably good outcome. And this was work from Pittsburgh that showed that stage 1 and 2 disease, HCC, small tumors, had a 5-year survival rate around 70 to 75%, whereas more advanced tumors had poor outcomes. You can see stage 3 at 50%, and stage 4 tumors at only 11%. And this was replicated by Vincenzo Mazzaferro, who was a fellow at Pittsburgh, when he went back to Milan. And he reported 48 patients with HCC in the setting of cirrhosis. Those that met stage 1 and 2 criteria, in other words, 1 lesion less than 5 centimeters or 2 to 3 lesions less than 3 centimeters, they had a 4-year survival rate of about 82%, versus those patients outside of those criteria had a survival rate of about 50% at 4 years. And this then became known as the Milan criteria. And subsequently, series that reported using that Milan criteria, in other words, less than 5 centimeters or 3 lesions less than 3 centimeters, had a 5-year survival rate between 75 and 80%. So this then became the indication for liver transplantation by the Barcelona Clinic Liver Staging Committee, showing that in the red box, liver transplantation applicable to those with early stage. But those patients with advanced tumors were not recommended to have liver transplantation. But we know that there are patients that are larger than, that exceed Milan criteria, that do have good outcomes based on other criteria, such as tumor grade, metabolic behavior, genomics, and other biomarkers, such as alpha-fetoprotein or PIVKA2. So this is just an example of using metabolic profiling. This is uptake of fluoroxydeoxyglucose or PET scan, using that to demonstrate that patients with tumors outside Milan criteria, which was PET negative, in other words, metabolically slow growing, have an outcome similar to those patients within Milan criteria, where those patients with, in yellow, with Milan criteria, outside of Milan criteria that were PET positive, have a very poor outcome. We've also demonstrated using genomics analysis. This is work from Pittsburgh, Wallace Marsh, and our group, looking at microsatellite imbalances. And this is an example on the top of in no allelic loss. You can see using micro dissection and genomic analysis. And then you can see on the very right a positive allelic loss. And we looked at a number of different, 18 in fact, microsatellites for polymorphisms in a variety of different oncoproteins. And by using a formula called fractional allelic loss, which is the number of mutated microsatellites divided by the total number of microsatellites, we could identify, using fractional allelic losses, those patients with very high levels of imbalances in red had a poor outcome compared to those patients where the fractional allelic loss was low. And this was then validated by the Mount Sinai group in collaboration with Pittsburgh. Patients within Milan criteria, you could see 35 patients, 3 of which had recurrence, about 10%. And those patients had outside Milan criteria, if their fractional allelic loss was less than 27%, had a 10% recurrence rate, versus those outside where the fractional allelic loss was greater than 20% had a very high recurrence rate, 80%. So advancing now in time, we applied other types of techniques to downstage the tumors, in particular local regional therapies of transarterial chemoembolization, transarterial radioembolization, in addition to radiofrequency ablation, microwave ablation, and SBRT, or stereotactic whole body radiotherapy. And by applying those downstaging technologies to downstage outside Milan criteria to within Milan criteria, you can see the 5-year overall survival rates in this group now approaches 90%. so anywhere between 60 and 90% survival rates by downstaging. Having moved to Chicago about 10 years ago, we adopted the Northwestern protocol of using transarterial radioembolization using yttrium-90 microspheres. And by doing that, we could show that TARE, or transarterial radioembolization with Y90, led to a greater drop in size of the treated tumors, which was statistically significant. Overall response rates, success in downstaging from outside Milan criteria to within Milan criteria was almost double, 58% versus 31%, and overall time to progression was almost double, 33 months compared to 18 months. And this then became the indication for our approval of the FDA for Y90 radioembolization for treatment of unresectable HCCs. And this is based on yttrium-90. You can see the overall response rates, 88%, with a 3-year overall survival rate of 87%. And those patients that went on to be resected or transplanted had a 3-year overall survival rate of 93%. Now, we've learned the radiotherapy also has some influential benefits in terms of immunological simulation. Radiotherapy induces cell death of the tumors, releases tumor antigens that primes the immune system, and this also changes the microvasculature of the tumor to enhance adhesion molecule expression and upregulates and recruits cytotoxic T cells to the tumor. This work from the Brian Goh's group in Singapore identified the upregulation of CD8 T cells, NK cells, NKT cells, upregulation also of molecules such as granzyme B, which cytotoxic T cells have, in the group of patients that were treated with Y90 and HCC. And you can see on the very far right, the genes that were upregulated in these patients included upregulation of innate immune responses, adaptive immune responses, and chemotactic activities. So in the Barcelona BCLC staging, the treatment for advanced and intermediate tumors was recommended to include systemic therapy. And the initial systemic therapies were the tyrosine kinase inhibitors, particularly sorafenib, as well as other VEGF, vascular endothelial growth factor inhibitors, such as Avastin, the bevacizumab. And these, this is the sorafenib SHARP trial that showed extension of survival for about 3 months, with an overall response rate of only 2%. But this was the first systemic therapy approved by the FDA for advanced tumors. We then began to understand the microenvironment within the tumor, particularly as it relates to an immunomodulatory environment, in particular the presence of tumor-suppressed T cells, and in contrast to T cell activation, which is mediated through CD8-28 and the CD80-86, what we really see is the upregulation of T cell inhibitory pathway co-stimulation, which is mediated through CTLA4 and CD80-86, or PD1 with PDL1 and PDL2. And so in the tumor microenvironment, what we see is that this immune checkpoint, which inhibits T cell activation, or it suppresses T cell activated T cells, we can inhibit this by use of antibodies, either targeting the CD80-86 pathway or blocking the CTLA4 and CD28 pathway. So what we really now have seen is the application of immune checkpoint inhibitors in HCC And these are some of the randomized trials that have been conducted. You can see the IM Brave 150 and the Himalaya trials, where durvalumab and tremelimumab compared to sorafenib, which is a tyrosine kinase inhibitor, each increased median overall survival rates and a decreased hazard ratio of death. And this is seen with most of the trials shown here with the immune checkpoint inhibitors alone or in combination with an anti-VEGF monoclonal antibody. And overall response rates, as you can see in the treatment arm with the immune checkpoint inhibitors, is at least 2 to 4 times greater than using in the control arm, which is the tyrosine kinase inhibitors. So now in the 2022 BCLE and the BCLC staging and treatment strategy, the incorporation of systemic therapy with frontline, first-line therapy with immune checkpoint inhibitors is now integrated into this strategy. And while the BCLC 2022 recommendations are for still advanced and intermediate stage tumors, we have now incorporated this in our treatment before transplantation as a way to suppress tumor progression or downstage tumors. And this early study from Patricia Tabrizi in Mount Sinai showed that PD-L1 inhibitors, nivolumab in particular, has an ability to suppress tumor progression and is safe to use as neoadjuvant therapy for liver transplantation for HCC. This example of the evolution of treatment, of the individualized treatment for HCC, can be applied to all of these tumors shown in here. These are primary and metastatic diseases. I won't go into all the details, but it's safe to say that the strategy of genomics, of understanding the use of immune checkpoint inhibitors can be applied to all of those tumors. Now, I would just want to end by talking about one strategy, which I think is, again, across all of the tumors that I showed you, which is the avoidance of calcineurin inhibitors, the cyclosporin and tacrolimus, because it has been shown that excessive use of these calcineurin inhibitors is associated with recurrence. And this is related to likely the upregulation of transforming growth factor beta, which is shown here with both tacrolimus and cyclosporin. And TGF beta has an impact on tumor cell growth and migration that is adverse. So the mTOR inhibitors, everolimus and sirolimus, have been used. Their indications for cancer therapy include neuroendocrine tumors, renal cell carcinoma, breast cancer, and prostate cancer. And sirolimus has already been shown to improve survival rate in patients with HCC. This has been validated by the SILVER study that showed that sirolimus-treated patients have better survival rate. And we also validated this with everolimus in a randomized trial showing that patients within Milan criteria within 2 years had about a 2% survival recurrence rate, which is equal to the tacrolimus-treated group. But in the everolimus-treated patients outside Milan criteria, there was about a 4-fold reduction in the incidence of recurrence. So just to conclude, liver transplantation is an effective option for patients with unresectable primary and metastatic diseases, tumors to the liver. Incorporating individualized medicine with tumor genomic profiling, as well as utilizing multimodality treatments, either to downstage the tumor as neoadjuvant therapy, or even using these in the postoperative period, can contribute to the success of transplant oncology. Of course, organ shortage is an issue, and we have been applying living donor liver transplantation in settings to provide optimal timing for patients that are completing their neoadjuvant therapy before liver transplantation. Thank you.